This topic is very dear to all of us. It's the bread and butter of an arthroplasty surgeon. Doing a Varus TKA with good success is of paramount importance to the brand of arthroplasty and for all the arthroplasty surgeons. This comprises of about more than 90% of our workload. The mechanical axis passing through the medial tibiofemoral joint with its effects on the cartilage, bone loss, medial contractures, and lateral laxity, that is the hallmark of a varus knee. So the aim always has been to perform a well-balanced TKA for long-term good function and survival. But the aim now is to have an extremely satisfied functional patient who has a forgotten knee joint. This is the aim which has been enhanced in recent past so that forgotten joint scores are the thing of the current importance. So objectives of any arthroplasty surgeon is to differentiate between the standard varus and a complex varus, identify the components which need correction, define your own alignment philosophy depending upon the varus magnitude, formulation of primary surgical plan and its backup plan, arrange for surgical inventory, and intraoperative replication of the steps planned. So these two patients are a completely different breed. They cannot be equated and treated the same way. This female who barely can walk without assistance and the patient who is walking with mild varus waddling gait will have completely different requirements intraoperatively. So the clinical assessment is to establish a distinct difference between the standard varus knee, which could be put in as a varus less than 20 degrees, standard varus and FFD less than 30-35 degrees, which are either fully correctable or partly correctable. It is very, very important to identify complex varus and tend to them preoperatively. Deformities which are non-correctable, knees which are extremely stiff, knees which present with collateral thrust indicating lateral and PLC's lengthening, a rare combination of varus plus hyperextension, medial tibial bone loss more than 10 to 12 millimeters, extra-articular deformity, and rarely you may have common peroneal palsy secondary to a lot of collateral thrust and varus. This is a rare combination of varus plus hyperextension, but we should keep our mind open to it. This female has to have an adequate medial and lateral balance. Otherwise, with such huge obesity, BMI of more than 35, if you do not adequately correct, this is bound for failure. This is another case which has a rare common peroneal palsy secondary to varus thrust, and this was proven with MRI as well as NCV. You can see there is a right foot drop, the right EHL, EDL, and tib and wound function. So keeping these into mind while pre-op assessment and finding out complex varus and their treatment is very, very important. Dr. Sunny has talked about preoperative radiograph alignment, so I'll skip it. Meticulous planning is very, very important. If you fail to plan, you might as well plan to fail. So meticulous correction by good exposure, primary releases, bone cuts, reassess, and then you do extended release. That is how we would be planning. I would still go with mechanical alignment as Dr. Jadhav was pointing out for anything more than 20 degrees. less than 20 degrees of deformity, alternative alignment philosophy could be entertained. When you have planned, executed, you have to have examination under anesthesia. One might be surprised with correction of deformities under anesthesia. Simple medial exposure with deep MCL release for adequate exposure and external rotation and subluxation of tibia. You can do it with cautery or an osteotome or a periosteum elevator. This type of osteophyte removal, especially sub-MCL femoral osteophyte removal, which tends the MCL, is of very, very great importance. If you tend to keep that osteophyte till the final, then you might over-release. So please get this sub-MCL osteophyte removed. I prefer to balance my extension gaps first and then go to balancing in flexion. You can adjust the flexion gaps by posteromedial release as well as rotational femoral changes. This is a small video. This posteromedial is done after the primary tibial resection so as to have access to the posteromedial corner. You can release the semimembranous and posterior capsule. This technique is the workhorse of complex varus reduction osteectomy, or also called as shift and resect. So you do the primary resection of tibia, following which undersize it by size 1 and then lateralize and resect the tibia. This indirectly lengthens your MCL. Despite all this, if you still have medial tightness, you might resort to MCL pie crusting with the 21 gauge needle. Tension it either with a spacer or a lamina spreader and feel for the tight fibers and release only the tight fibers. So once you have flexion extension gap, then one can go ahead and do the spacer block followed by implantation. If you have large tibial bone defects, plain screws, screws with cements, bone graft are the choice. In complex varus, you might come across these situations where you might have some residual laxity on the lateral side. So you might resort to additional medial release, posteromedial release, and larger poly. If you have deformities less than 20, if they are correctable, partly or fully, you can go ahead with a CR implant, which rarely requires a lot of PCL balancing. If for more than 20 degrees, you might have to do a intraoperative PCL balancing from the tibial or the femoral side. For deformities with large bone loss which are not correctable, or a patient who has inflammatory arthritis, extensor mechanism deficiency, or patelectomy, you might have to go to PS knee. And if you think you are not stable enough, you might have to go to a higher post or a more constraint implants. Alternative philosophies are now catching up very fast with the need for better patient satisfaction. So these are a few nomenclatures: kinematic alignment, restricted, reverse K, functional. You can choose your vice, but be expert into it. A small thing on robotics. This is the best thing which has possibly happened, because the subjective assessment of surgeon has been converted to objective assessment. You can deal with millimeters, 0.5 millimeters of resection, angulations, and ligament tensioning. And the safety is enhanced because you have haptic boundaries. If you undercorrect the deformity, if you leave it in varus, you might have complications because of undercorrection, loosening. If you overcorrect, you can have complications of laxity and early failure. So being right on the spot is of great importance. So in conclusion, varus knee is a very rewarding procedure, but it takes meticulous planning and meticulous intraoperative replication of surgical plan. And with evolving paradigm, we might think that personalized alignment philosophy is going to be the next gold standard that time will decide. I thank you for your patient listening. Thank you.